I just thought the privilege of getting to know people and hearing their stories. I think ultimately psychiatry is a lot about stories, and seeing people really at the low part of their life when they were very vulnerable, and you were there in a position where you could turn that around. And I saw that happening again and again. There's quite a lot of negativity about what can be done, but my observation was there was a lot that you could be done, and working with a team, and you could turn people's lives around.
You have found the Thinking Mind podcast.
Thanks very much for coming on the podcast.
Well, I'm delighted to be here, Alex. Thanks very much for inviting me.
There's so much to talk about, isn't there? It's been a crazy year. There's COVID. We've got everyone locked in their houses. Everyone's reckoning with the limitations of their own mental health. Simultaneously, we're seeing this political polarization accelerated by social media, accelerated by everyone being locked in their houses. So there's this real tangle of different problems that are affecting each other. And I'd love to get into all of that with you, being the position that you're in the first 6 months now of your presidency. But before we get into that, maybe you could tell us a bit about what was your path into psychiatry, and what does being a psychiatrist mean to you?
So I was fairly sort of directionless child, I have to say, much to the frustration of my parents, who were lovely people and gave me every opportunity, I guess. But they used to organise things like guitar lessons, and I would go to the guitar lesson and not take my guitar, which is kind of slightly, I think, gives you a bit of a message. And so I didn't do massively well at school, but I was pretty good at sciences. And so one of the things, if you were reasonably good at science, you might think about going to medical school. I never thought I would get in, and I only just about made it. I applied to Guy's Hospital Medical School, and I didn't get my grades, but I went up to the medical school office the day that the results came out and said, I really want to come. Will you just accept me? Even though I was the first person in my extended family to go to medical school. And I think my parents were a bit surprised that I got in. But anyway, I did get in, but I didn't go in with a mission to do psychiatry or anything else. I just thought, oh, well, here I am. And I didn't massively enjoy medical school, at least the medical school bit of medical school. I did a lot of cycling. I did a lot of rowing. I did athletics. I met my future wife, my wife. And so those were really, those were great things. And then I did psychiatry, and Guy's had some really inspirational psychiatrists who were committed to what they did. They were interesting people. They had interesting things going on outside of their immediate work that they were very happy to talk about. And they were the first people that actually asked me and the other medical students what you thought about things, what you thought about patients. And I was on a firm with an amazing psychiatrist, Dr. Raghu Gained, who was really my inspiration. He was fun. He was engaging. His job meant everything to him. He was fabulous with patients. And I remember getting in, he had an open top Golf GTI, and medical students used to bundle in the back of his car and go off to New Cross to do domiciliary visits. And so there we are. Actually, we were going into people's homes, and I thought, well, this is really different to the rest of it. And so we felt engaged, and it seemed like fun and worthwhile. And so that's what really appealed to me. I thought, well, that's what I want to do. And then I qualified, and I did my medicine and surgical health jobs as you did in those days. Actually, I enjoyed that. I thought, well, actually, I got myself stuck into something where there was real purpose and I could do something with. And I didn't find medical school really did that. So, and I thought, well, maybe I could do medicine or surgery. I thought, no, I'll go back to what I really thought. And of course, you had no experience of psychiatry as a job in what is now the foundation years. So you didn't have something to measure it against. I thought, no, I'll go back. I'll do psychiatry. I applied to the Guy's scheme. Actually, I was put on the reserve list. Actually, I didn't get in first time round, but fortunately, I did manage to actually get a job straight off because somebody must have not accepted the role. So there I was, so doing exactly what I wanted to do, but it was very much that experience of psychiatry as a medical student.
Mm-hmm. And now, the way I find it is, as the years go by and I go through my training, I find the way I think about my job starts to change and evolve. Can you give me a picture of how psychiatry, being a psychiatrist, has changed for you, and what do you think of as being a psychiatrist now when you go to work?
One of the interesting things was in terms of how it evolved. It partly evolved because I discovered things about my family that I wasn't aware of growing up. And I don't know how much that influenced what I was doing, but there actually is a lot of mental illness in my family. Actually, I think it probably is in almost every family, in fact. But my father was one of 7 children, and there was a lot of mental illness amongst his brothers, in my cousins, and it wasn't really something that you spoke about. So as I became aware of that, I think that made me think, well, this is something that everybody can experience. It's not just something that happens to other people. It can happen to anyone, and it has happened to my family, and I wasn't really aware of it. And of course, I then, and I've spoken frequently about this, in my 40s, I developed a mental illness myself. I became depressed, and I hadn't really had a day's mental illness in my life. If I'm honest, I was probably somebody who thought that mental illness was something that happened to somebody else. It wouldn't happen to me. And then there I was depressed. I took 6 weeks off work. I took antidepressants, and I did get better. It actually took quite a while, and then I had another episode. So that was quite a profound influence on what how I practiced. But also, I thought my training was such an enriching experience. I just thought it was amazing. You spent 6 months doing child psychiatry, 6 months intellectual disability. I was doing old age psychiatry, and I did forensic psychiatry. I became a forensic psychiatrist. I just thought the privilege of getting to know people and hearing their stories. I think ultimately psychiatry is a lot about stories, and seeing people really at the low part of their life when they were very vulnerable, and you were there in a position where you could turn that around. And I saw that happening again and again. There's quite a lot of negativity about what can be done, but my observation was there was a lot that you could be done, and working with a team, and you could turn people's lives around. And that's what really spurred me on to say this is absolutely the right career for me. That engagement with people, the scientific approach, seeing people as everything that they were, and looking at what they wanted to get out of their episodes of care, not just controlling symptoms. So, and that again, that profoundly influenced me.
Yeah, I agree. I think there's a huge difference between the public perception of how much one can treat and move on from and recover from and even learn from mental illness and difficult mental experiences, and the actual truth, which is there's a wealth of experience. We have now a history of great clinicians, as well as a history of missteps, which we can talk about as well. But there's a huge gap between what people think can be done and what actually can be done. And it sounds like for you, what what's critical is the ability to be there for someone when they're at their lowest, and to be able to make that impact.
I mean, absolutely. And in so many different parts of their lives, in child psychiatry and intellectual disability and in forensic psychiatry, I always found it was just the most amazing thing to go into a prison when somebody had been arrested for a really serious offence. They sometimes had very difficult experiences within prison, and they'd often been on the press. They were some of them were hate figures, and to be able to invite somebody into a room and say to them, look, I know what's going on here. I've seen this before, and I want to hear from you about what your story is, what's happened to you, and how you're there in front of me. And then I want to be able to help you guide your way through the system, because the legal system is very complicated, but actually help you to achieve the goals that you really want to achieve, and to look at how your very early life experiences have influenced your thoughts, your emotions, your behaviors, and how we can actually work on that with you so that you're feeling in a much better place. And I just thought that was just the most amazing thing. Sometimes people would come into a room, they'd be frightened, they'd be shaking, and they'd be very, very paranoid, even if they didn't suffer from a paranoid psychosis. And to be able to turn that around and say, look, okay, I can see a way forward here, and I can genuinely, and actually, not only can I see a way forward, I can bring that about. And I just thought that was the most uplifting experience from the such a sort of low ebb of the person who's in front of you.
Mm-hmm. It's a very compassionate point of view, and I think one of the best things about our society is that we don't entirely reject people when they're at their lowest, that we are able to accept that even people who have committed crimes are worthy of dignity and respect and of treatment. And I myself have worked in a forensic unit, and I really enjoyed it. What kind of unit do you work in, and what does your day-to-day job look like?
So I'm a forensic psychiatrist. I work for Devon Partnership Trust, which is the mental health trust for Devon, other than Plymouth. And I currently work in a low secure unit called Chichester House. It's a 15-bedded unit, all male patients. And on our site, we've got about 110 beds. We've got some open units. I've worked on those units over the years. We've got a medium secure unit, a 60-bedded unit, and 2 low secure units. So I've been there now for nearly 29 years in the single hospital. So I'm now the president of the Royal College. I work 2 days clinically on a Monday and a Tuesday. So I go into work, I see my patients, I work with the team, I do my clinical review meetings, my care program approach meetings. I mean, to be honest, I do quite a lot of college work when I'm actually at work as well. My employers do know that is the case, but it's the nature of the job. So, but I do most of my clinical work on those Monday and Tuesday, and the rest of the week I do the college work, and in evenings and weekends. And at the moment, that's all completely remote. So I'm where I'm speaking to you from at home in my house on Dartmoor. And so it's very different. Other than that, I would be in London for the rest of the week at the college, or all over the country, speaking at meetings, going to committees, and even our global reach. So I'd be doing a bit of that. So that's roughly how it divides up.
I think if you look at history, you can really think of times when things are relatively stable and status quo, and things are kind of moving along at an even pace, and periods when there's a lot of rapid change. And certainly most people would agree, anyone that watches the news would know that we're in a time of rapid change. It's very tumultuous, it can be destructive, but of course it's also a time for creation and innovation. Do you find it exciting to be in such a leadership role in such a time of change?
I mean, to be honest, Alex, I feel almost a sort of sense of guilt to say that I'm actually enjoying my work. I mean, some of it is pretty harrowing stuff, and it's so the stories you hear about what's happening in relation to COVID. It's it's very easy to get into either an internal dialogue or a dialogue in meetings or with friends on Zoom meetings to say, well, when this is all over, it'll be great to go out for dinner and how nice it will be to have your family round. But I'm very much aware that there's such a huge tragedy for lots of people. There'll be people when it's all over. It won't be all over because there'll be people missing. There'll be people missing from photographs who wouldn't have been missing without COVID. So, and that the ripples that around families and friends of all of that, to say nothing of people's personal experience of having had COVID, having been ventilated, having lost people, seen people suffer, and all the economic and social impact. So it's a terrible thing, and I feel that I'm in a very privileged position that this thing that everybody else is living, I have at least an opportunity to influence what's going on, particularly in the mental health world, but beyond that as well. So I'm on regular meetings with the chief medical officer. I can ask any question of him, the medical director of NHS England, the Secretary of State, and so I find myself in a position where I'm in a position of influence, and I guess a bit like those patients that I saw when you go into a prison at sort of a low ebb. You think, well, what a privilege to be in a position where you can help to move things on from there. So I find that stimulating and energizing, but also I think traumatizing as well. And so it's that combination of things. But I guess for all of us, if you have an opportunity to add some value, then that's what your basic humanity is all about. And that's kind of what I experience. So I have very long days. I have lots of meetings. You have to keep on the ball about everything. There's a lot about the system architecture, how it all actually works. And but then the privilege of having some influence and people actually listening to what you're saying is amazing. So I think it's a central part of your humanity.
Yeah, it's a really double-edged sword. I find the best and worst thing about being a doctor is that you're in touch with the unforgiving aspects of life. So in psychiatry, we might see the 21-year-old that's diagnosed with schizophrenia, or as a general physician, you might see all sorts of difficult illnesses people never recover from: COPD, severe metabolic problems, being born with genetic abnormalities. We're in touch with some of the more tragic aspects of what it means to be alive and to be a person. And while that's incredibly harrowing, as you said, it's a strange privilege in a sense, because it allows you to really appreciate the positive aspects of being alive, and it allows you to be in a position to help and to feel that not only can I better appreciate my own life, but I'm in a position to positively impact the lives of others, which I think has always provided a sense of mastery and a sense of joy, which it's really necessary to have a dose of that in order to get through life. In your liaison with the government and government officials, how seriously do you think they're taking the potential mental health impacts of COVID and the aftermath of that?
I think it's got a lot better, because there is I think a conversation which is now going on in the general public, in the press, And I think MPs have their constituents who obviously remote surgeries now, they could come and see them. And I think that everybody has now accepted that there will be huge mental health implications. Right at the beginning of this, we were actually saying that this is what would happen, that COVID won't be over when the virus is under control. There is the mental health implications will roll on for 18 months, 2 years and beyond. And I think a lot of people were saying, well, look, we were being alarmist. And I think now people actually really do feel that this is actually what's going to happen. And I think people want to get into a dialogue about it. When I'm on meetings with the Secretary of State, whether it's individual meetings or in group meetings, he appears to accept that, and as do other parts of the system. But as in all of these things, the most important thing is action. I mean, in England, there's the extra 500 million for mental health as a result of COVID over the next year. I think that was, a positive sign, but there's a huge amount more that needs to be done beyond that. And I've always been somebody who felt that it's about actions. It isn't about what you write down or what you say. It's about what happens and people's experience of what happens. I mean, I've done a lot of media today. We did a story about beds and the lack of beds that are available, people still being sent out of area. So I was doing radio from 6:20 this morning, and actually with all of them, I was the people who interviewed me were starting with a dialogue, completely accepting. I was going in, waiting to say how things were, and they were starting with a dialogue saying, well, this is how things are. So I thought, well, actually, that's a good thing. I think there is an acceptance. What's my job to do now is to engage people in a more detailed dialogue. And then there's what's going to happen? We've had the plan and we've had the facts and figures about the physical effects of COVID. We now need to have a plan about the mental health effects. I mean, one of the things I've said a few times recently is that when you see the briefings at Downing Street and you see the 3 podiums and people talking about their various areas of expertise, there should be a 4th podium with somebody who is talking about the mental health implications, and that will be more necessary going forward. And I genuinely think that's really what should happen, because I think that is going to be the main concern, probably the latter end of the summer.
I think people are more accepting of the notion of the importance and also the fragility and the vulnerability of our mental health now, because everyone's experienced how fragile it is firsthand. So most people have experienced either solitude, economic problems, some sort of restriction, and also, besides those more specific problems, the impact of that general tension of the whole country or really the whole world being in that general state of tension and fight or flight for months on end without a clear ability to do anything about it in the short term. Getting into more detail, what do you think are the pieces that need to be put into play in order to deal with the mental health impact? And in terms of the extra funding, the 500 million, where do you think that should be allocated, broadly speaking?
I think we do need to bring the virus under control. Sometimes the mental health implications have been used as an argument to say, well, we should be doing less in terms of lockdowns, and I've never held that view, because the virus itself has very direct implications. So we do need to do that. I think beyond that, we need to look at the people who haven't been receiving the treatment that they should have been receiving. We know that the earlier you treat mental illness, the better the outcome. And although there has been an increase, and in fact the in terms of urgent and emergency work, that's been higher than it's ever been. I think there are still some people who are very worried, they are very concerned, they've hidden themselves away, they don't feel they can access treatment, they are too frightened to access treatment. And I think there will be, identifying who those people are and making sure that they get the treatment that they need is absolutely vital. I think as a community, I don't think it's going to be that easy for all of us just to go back to how things were. I think there's going to have to be a conversation and quite a lot of help, I guess, particularly children, to actually go back to how things were. And I think they're going to need a lot of help and support. And of course, children have suffered more than most. And I think they're going to be children who would have been identified, for example, in schools, who won't have been identified as having had a mental illness, and we need to identify those and get them help quickly. I think we are going to have to ask government to fund mental health services to an even higher level. Before the pandemic, we know that the adult psychiatric morbidity survey showed that only a third of people who could benefit from evidence-based treatments actually got them. And so already we weren't doing what we would all wish to do. And COVID will have produced an increase in the demand. The Centre for Mental Health estimate that it'll be 500,000 extra people presenting with mental illness every year for the next 5 years. I think that's pretty reasonable. So we're making up for lost time, but then there'll be the additional demand that will come from COVID itself. So I think the things I'd be looking for is an acknowledgement on the part of government, realism on their part, actually having a plan with something of the urgency that actually fighting COVID has had. I mean, we'll have all different ideas about how well things have gone, but it certainly has brought people together. It's focused communities, it's focused policymakers and politicians. And I think we need that sort of focus around mental health. We're going to need investment. We're going to need to make sure in terms of workforce that we get the investment in our workforce. Obviously, that can take a while until people come on stream, but we need those sorts of actions pretty quickly, and we need a recovery plan, and actually not least for people working in services, obviously psychiatrists, but in everybody in mental health services, in physical health services, and in social care, because I don't think that the whole system has been in crisis for a year. We can't just keep on in crisis forever. People are going to have some time to recover, and I'm a bit concerned that when the virus is under control, we're able to say, well, look, there's a huge backlog of everything. Just get on and sort the backlog out. And you just can't run the system that hot for that long without having very severe consequences for the mental health of the workforce.
Is there any data about what type of presentations are increasing? You mentioned that A&E and acute psychiatric presentations are increasing. Is there any data on what kind? Is it more depression? Is it more overall suicidality? Is there any notion of
I think you can divide things up. There's the coroner survey that you study that you would have heard of, which is an attempt to look at the very direct effects of COVID on the nervous system, both in terms of neurological disorder, but also psychiatric disorder. They published their first tranche of the database that they're encouraging people to report into their database about people that are sort of have de novo presentations of mental illness and neurological problems. And what they found was that there were new cases of dementia, of psychosis and depression that seem to be directly caused by COVID. We do have an increase now in urgent and emergency work. Yeah, but and a lot of that, I think, will probably be people who haven't presented earlier and now they're coming forward. We also know from the ONS studies that anxiety levels are up, depression levels are up, well-being is down, and so we can already see that there are more symptoms of mental illness, and actually evidence that there is more mental illness. And of course, post-traumatic stress disorder, we know that it's now very well established that certainly 20% of people who have been ventilated will have post-traumatic stress disorder. And for those who are actually working in intensive care facilities, the staff, about 50%, will have some symptoms of post-traumatic stress disorder, even if not the full-blown mental illness. So this has implications for the public, but also for staff. And of course, the sorts of protection that we all have, the meeting with friends and family, people asking how you are, saying, well, look, you don't look quite right today, and the support that we have through work and mixing and socializing, that's pretty well all gone, or is much more challenging to arrange, and is arranged in a way that doesn't give you a lot of the benefits that those face-to-face contacts, that sense of real community, people actually physically together, that you get with that. So there are so many different strands. And then, of course, we'll have the long-term social and economic consequences, and we know that mental illness is heavily socially determined. I was speaking to Michael Marmot about this just yesterday, and the implications, and we know that all the dials at the moment are going the wrong way. So, and we know the evidence is very strong. So we would expect, because of that, that we will have people suffering from anxiety, depression, obsessive compulsive disorder. Just one more area, and that's eating disorder. I think there's some real concerns about children with eating disorder, isolated at home, and I think that's going to be a very real issue.
I'm beginning to get a sense of the harrowing feelings you were talking about at the beginning of the interview. Would you think it's fair to say that these are all obviously the common denominators, the stress of this pandemic, and these are all just different manifestations of stress, and that's people tend to have their own particular way of responding to stress, and some people, they're more vulnerable to a depression, some might be more vulnerable to a psychosis, some to an eating disorder?
I think it's stress and it's anxiety. I believe that anxiety underpins a lot of mental illness, and it then manifests itself in very different ways. There's clearly a lot of anxiety, uncertainty, heightened arousal, which we know again is a potent cause of mental illness. And so I think there are some common denominators, as is the not only the direct causes of illness, but actually the protective factors just not being there, or being there in a very, very different way. So in some ways, it's hardly surprising that we're going to get an increase, and you don't need to be a psychiatrist to spot it. The question is, as psychiatrists, what are we going to do about it?
Do you think that the role of psychiatry, given that now mental health has now started to explode into a public health problem, really in a way that it hasn't been before, do you think the role of psychiatry is changing, and that we have to become more adept in how to help people prevent developing mental health conditions, become more resilient, deal with stress, deal with anxiety?
Yes, absolutely. I agree 100%. I think most psychiatrists would say that they spend most of their time probably firefighting. They would see it, but seeing people who are acutely unwell, who have quite often had an illness for some time, that people haven't been able to access treatment, or because of stigma, they haven't come forward. So we see people who present relatively late, And it's of paramount importance that we give care and attention to those people across the age span. And because of that, and there isn't enough of us or any mental health professional to address that need, to then start saying, well, what about prevention? That's a key part of what you do. It can, I think, seem understandably irrelevant, and it can also seem like something that you couldn't possibly find the time for. And I completely understand and respect that. But I think it is the first duty of any doctor to prevent illness and then do no harm. And so we know that mental illness is heavily socially determined. And so I do feel we've actually now written into the key objectives of the college, prevention is there, and it wasn't there until relatively recently. We have to look at prevention, and we have to look at the wider social determinants of ill health, and we need to be active in the way that we try to address them. I mean, I guess this really first came to me. I mean, I'm a forensic psychiatrist, so in some ways I'm sort of the ultimate person who deals with people with severe mental illness at the end of a long story that often starts with traumatic experience very early on in life and later developing a mental illness. And then I got involved in parliamentary work with the college, and I chaired the Westminster Parliamentary Committee. So I used to go to all the party conferences. For 5 years, I went to the Labour Party conference, the Tory Party conference, the Lib Dem Party conference. I also went to the SNP conference, and I used to sit in rooms with MPs and lots of councillors, and they would talk about deprivation, and they would talk about different wards, councillors who in their ward, they would say the life expectancy in my ward is 2 years less than the one next door. And this is terrible, which it clearly is. And people would try to unpick why that was. And I guess this sort of opened my eyes to the social determinants of illness and everything else, and the lack of opportunity. But I used to stand up at those meetings and say, well, that's obviously very important, and that's, we need to do something about it. But all of you, within all of your wards, if you're councillors, you will have people whose life expectancy is 15 to 20 years less than everybody else. And that will be in everybody's, every part of everybody's constituency or ward. And those people have the most severe forms of mental illness. And they're the group we really need to be concentrating on. And then I became more interested in public mental health. The college published an amazing document. I think Cambury and Jonathan Campion really led on that and really published the evidence and also what we should be doing about it. And I used to sort of wave that in people's faces and say, look, we've got to do something about this. And that evidence is still there. It's in the Marmot report. It's in the Marmot review 10 years on, which has just been published. And we need to be active in terms of influencing our local councils, in influencing people nationally. We recently, there was a special edition of the Psychiatric Bulletin. Peter Byrne, who leads on public mental health, he and I wrote an editorial around the importance of this issue, and it's important for all of us, and we all need to be active in this space.
I first became aware of this notion of prevention more around physical health, looking at in certain conditions like type 2 diabetes, hypertension, obesity, in terms of how they were treated in the clinical mainstream and how there started to be newer, more holistic treatments being developed in clinicians who were less inclined to go with the mainstream view. So, for example, in diabetes, it's now starting to emerge that with the correct nutrition, type 2 diabetes can actually be reversed. So if you give someone foods that don't have a huge insulin requirement, then obviously that patient's insulin requirement goes down, and the pancreas has some time to regenerate, and that they can actually improve in terms of a lot of their symptoms and their actual physiology. And if it's true for physical health conditions, it must be true for mental health conditions. There is such a thing as good mental nutrition, I feel, and a good mental environment that's actually conducive to health. You know, we know it with something as basic as our teeth. Like, we don't wait for our teeth to rot before we start to address the fact that our teeth need maintenance. We maintain our teeth twice a day without even thinking about it. So the fact that it's still such a novel thing in our societies, that our mental health is something to be cared for and maintained, is shocking in a way. But certainly it seems to be coming more to the fore now. In a practical sense, what do you think, if there are a couple of things you could implement to improve the country's mental health, what might they be?
I think, first of all, you would look at people's early life experience and ensure that all children got the best possible start that they can, and that those who are most disadvantaged and those most disadvantaged families, that they get the help and support and opportunity that they need, that all children get a fair go at life, that they have opportunity to develop, that they're nurtured, and they have an opportunity to contribute and to get to where they are. I think there's another big issue here, that in relation to racism and structural racism, and it's one of my 4 priorities, that there's lots of deprivation that goes alongside people from Black, Asian and minority ethnic communities, but that doesn't explain everything about their experience. There is something very specific about racism and structural racism that needs to be addressed, that is also key to good mental health, and we need to address that really head on. I guess the other most important thing is to do with stigma, and the reason that people often don't come forward for treatment for mental illness is because they don't have a conversation with themselves. Actually, that's where it starts. They don't have a conversation with those who are their nearest and dearest, and they're reluctant to go and see their doctor about it. And if we had more of a conversation, I think actually we could help each other a lot more if it became an ordinary thing to be able to say to somebody, you know what, actually, I'm kind of feeling life isn't worth living, and I'm even thinking about taking my own life. If that became something that, if that's how you were feeling, you could easily say that to those around you, I think that would be a huge step forward. And then actually that you can talk to your doctor about that and your psychiatrist about that, I think that would be a huge step forward. So I think it's those early things and quite basic things, but then there are some very specific practical things that you can do that will help with your mental health. I guess the one that I probably most make use of is exercise. I think exercise is very important to my mental health. But I think there is something else that I would say, that we know that if you attend to your physical fitness, and if you attend to your diet, and there are certain things that you avoid, like not smoking and not drinking too much alcohol, that it will generally have a better effect on your physical health. But it doesn't actually, your physical fitness doesn't mean you can't develop a physical illness. And I think that's also true with mental illness. And if we look, I guess the equivalent would be the evidence base around well-being, that I think it's very important that we attend to that. But I don't see well-being and illness as being on a continuum. they cross over. There is a connection. If you can look at your well-being, and that will reduce in many ways your chances of developing a mental illness, but it won't eliminate it. It doesn't mean that that's inherently something. You haven't been addressing your well-being, you become mentally ill. And say that the same is true with physical illness. So I think I'm always a bit cautious about the well-being issue. As much as I support it, it needs to be tackled in a very particular way.
Right. So you're saying there are essentially two dimensions: the dimension of how things can go wrong, the pathology, but also a positive spectrum of how well things can go. And you said you don't see them as a straight line. I think I'm curious about that. I think I always thought of it as a straight line from one to the other, but you're saying no, they need to be treated separately.
Yes, they cross over a bit. So it's like being, your physical fitness and your attention to your physical health. It doesn't stop you developing a cancer. It may reduce your chances. It doesn't mean that you shouldn't address it. That's a very positive thing to do. But there are other things going on that can sometimes, I'm afraid, just happen.
Yeah, that makes sense. So there are precautions that one must take to try and serve as a bulwark against things developing in a negative direction. And there are also obviously positive things you can do, and you need to be thinking about both spheres.
Yeah, absolutely.
Talking specifically, you mentioned race and the problems of racism, which is obviously a huge ongoing issue. And it's an ongoing issue specifically in the mental health world, of course. Looking at statistics, there are a number of statistics pointing to worse outcomes for people of minority backgrounds. Of those disparities, what do you think is your priority? And what do you think are the practical steps that can be taken towards addressing them? So some of the disparities, for example, that people of ethnic minority backgrounds are more likely to be sectioned. Which do you think are your priority, and how might they be addressed?
I think, again, it is people's early life experience, I think, and their opportunities and their experiences of how their fellow human beings interact, treat you as a human being, and their perceptions of you and their prejudices to do with you. I think there's a huge amount there that needs to be addressed, which has a profound effect on the people's experience of racism, and actually the causation of mental illness that goes along with that. But I think the other thing that we need to do is to make sure. I mean, there's a real issue to do with trust and suspiciousness of services, and quite rightly so, because of people's experience of authority and health and how they've been treated. And there's a huge amount of evidence around how people are, sometimes in subtle ways and sometimes in very unsubtle ways, how the system within health treats people from Black, Asian and minority ethnic backgrounds very differently, that unless you really look at it, you don't see it. But it's a very strong evidence base around that. But so we need to work with communities to ensure that we can develop services that people welcome, that they trust, that they will want to engage with earlier, and importantly, employs people at all levels in leadership positions, and the person you might actually see, people who they recognise in themselves, people who look like them, and people need to see that. So I think how we actually construct services, I think, is really important. And I think the educational piece for psychiatrists as well, for me as well, I've dived right into this issue, and I'm still learning every single day about this. And it's been, I think, I would say it's the most educational experience I've ever had, actually immersing myself in racism and I should have seen this all before, but I would like to think that I really get it. I wouldn't want to say that I completely understand it and have all the solutions. I think we're all on a journey with this, but I think there is so much that we can do and that we should do, and I'm determined to make sure that the college does all it can to address that.
So there's something to be said about this dynamic process of building a longer lasting and sustainable relationship with these communities, through action, through a willingness to learn, change, adapt, so that people feel more able to trust services. Because, of course, if people don't feel able to trust their services, then they're not going to present. And if they don't present, then things get worse.
And it's you can't just say to people, look, we've done this, trust us. Trust is something that has to be built upon. You have to understand where people are coming from in order to address their concerns, but then you have to go on a journey with them so they can build trust. Trust has to be earned. It can't just be sort of given.
I wanted to ask you, could you fill us in terms of where things are at with the Mental Health Act reform, at what stage that's at, and what are the changes that people need to know about?
So I sat on the clinical advisory group for the review. It was chaired by Simon Wesley, one of my predecessors, and I think he did an amazing job. He brought people together in a spirit of exploration, of openness and honesty, but in a sense of realism around the timescales that we have and the difficulties of getting things through Parliament. And so he published his report, and the government have just published the white paper, which is kind of their response to the review. And I have to say, I've been very impressed that the government have largely accepted everything that the Wesley review recommended. And I think I really do have to pay tribute to Simon. He's very politically savvy. He worked very well with politicians across all parties and with civil servants. So I think he had a grasp as to what's deliverable and what isn't. But I think it's pretty well unheard of that you have such a review. The last review of the Mental Health Act, the government basically said, we're all saying this, but we're going to do something completely different. So we're in a very different position here. I think there are some fundamental things that there'll be changes in. I think that there's I guess the underlying ethos is greater respect for autonomy, choice, and for safeguards, and for people being cared for in the least restrictive environment. So I think they're going to be written in to the Act. And I guess then there are some actions that flow from that there will be more of an emphasis on a statutory care plan. I think most of us would have a written care plan for our patients, but this will bring it on a statutory basis that we have to have a care plan that's drawn up in a reasonable period of time, and that some aspects of that care plan are challengeable. I guess particularly for those who have capacity, who have very particular views about what they want, that there will be a greater emphasis on respecting those views. But if psychiatrists feel very strongly that they want to go against them, there'll be an opportunity to have more second opinion doctors, but also more work through tribunals who perhaps won't be able to override the clinical decisions, but there will be an opportunity for a dialogue, which I think will probably bring about some change. So respect for autonomy and the views of patients, that will also mean a greater sort of frequency in terms of renewing sections and reviewing things like community treatment orders, much stricter criteria for things like community treatment orders. I think some very obvious things that are not at all controversial around things like instead of your nearest relative, where there's sort of rather arcane hierarchy of who is your nearest relative, that you will actually have a nominated person who you can say, this is the person I want to represent me. And it could be outside of your family. And again, there's a traditional view about what is your family. So I think that's all really very positive. I think where there'll be issues where there will be more concern. I guess one is actually this is going to cost money, so more tribunal doctors, more tribunals, more advocacy, and advocacy that is tuned to people's ethnicity and cultural aspects, and more training from that point of view. That's obviously a very positive thing, but it's going to cost money, more tribunal doctors, more second opinion doctors. But safeguards and all that means takes time. You can't do safeguards on a sort of slapdash basis. So for all of us, all the psychiatrists, we will spend more time doing this. And so we need more psychiatrists in order for us to be able to pay more attention to this. So I think the money that will fund this, I think, will be crucial, and make sure that we actually get that the system doesn't say, well, this is great, just do it, but there's no money to do it, because everybody just becomes more frustrated. So I think that's one thing. One of the areas where there was a change from the recommendation of the Wesley Review was that autism and intellectual disability will effectively be taken out of the Mental Health Act, other than purely on an assessment basis. So you could detain somebody for assessment who has intellectual disability or autism, just purely that, not with an addition, with a mental illness alongside that. You can assess them, but you couldn't, for example, then treat them under a Section 3.
So just so because people might not be aware, so that would mean that people with autism and intellectual disabilities could be sectioned potentially for about 28 days for what's called a Section 2 for assessment, but they couldn't be sectioned for up to 6 months under a Section 3.
That's absolutely right, unless they had a mental illness alongside that, and that would be the reason for detaining them if they needed to be detained. Of course, there's still the Mental Capacity Act that can be used. The other interesting thing is that the white paper says that this applies to Part 2 of the Act, the so-called civil sections, so Section 2 and 3, but it doesn't apply to Part 3 of the Act, that are those that are the sorts of people that I help, the people who are coming through the criminal justice system. So on sections like Section 37 or Section 3741, it doesn't apply to them. And I can see why they did that. There's concern that we will have people who have intellectual disability or autism, for example, in prison, being very vulnerable. And so to safeguard them, I think there's been a pragmatic approach to say, well, actually, maybe that's a step too far, and that they can be brought into hospital. But I don't think you can look at these things. I think that's actually discriminatory in itself. You can't say one rule applies within a criminal justice sphere and another applies within a civil sphere around this particular issue. I think you've got to go one way or the other. So I think that's going to be that's probably going to be the area where there will be most concern.
Right, so there's still some controversy in the difference between civil and criminal justice, but it sounds like broadly patients are just going to have more of a say and more of an influence over, I guess, what happens if they are detained under a section, the nature of their care plan, and I guess the details of that, and that might include what treatments they receive or don't receive, I suppose the length of their stay in hospital. And you also mentioned that it will become much harder for people to come under a community treatment order, which is, again, for people who don't know, it's kind of the enforcement of a section, but in the community in terms of what treatment they receive.
So I think it's the white paper's been published. There is a consultation. I would recommend that anybody listening to this, that you read the white paper. this is going to be the future for many of you working within psychiatry, that you respond. The college has formed a group that I'm chairing that will look at each and every recommendation and will give a college view about that. We will be consulting with members about that as well. And the government will then respond to the consultation. There's likely to be lots of committees that will go through Parliament that will look in even more detail about some of these recommendations and what they will mean in practice, how practical they will be, and how much they will cost. And then there will be a bill that will be presented to Parliament. Again, there's opportunities in the House of Lords, in the House of Commons, to put down amendments and to change what's happening. So we have a lot of opportunities to influence the end result, but it's probably going to be a couple of years until an act is passed, and then it's likely that there'll be another couple of years before the act actually comes into practice, because often you do need a bit of a run-in to get the system ready, to train people in the new ways in which these things happen. So I think there won't be any changes on the ground before 4 or 5 years would be my guess, and that assumes that it does all pass through Parliament.
What other developments in psychiatry or mental health more broadly are you most excited about?
I think there are going to be huge developments in neuropsychiatry, and I don't understand a lot of it, but there are some amazing psychiatrists who are working in this field, how we actually understand that the brain, how we look at psychopharmacology, how we'll be able to target drugs much more effectively, that we will be able to identify who will respond to certain drugs, and so therefore which drugs we should actually we should prescribe. I would hope that we will get more investment in research around treatments, including drug treatments, and that really has largely ground to a halt. There've been pretty well no new drugs in psychiatry for the last decade, anything that really is very substantially different. And I think we really need to address that. But the richness of psychiatry is that whole biological and psychological and social. I've already spoken about the social determinants, and I think there is more work that we can do on that front, which I think is actually very exciting. I think it'll make a real difference, and we need to engage with that. But I don't see psychiatry as being a sort of polarized. It's moved to the biological, it's moved to the psychological, and I think there is some exciting developments in psychological treatments. I think that the IAPT program has actually been a good thing. I know some psychiatrists think it's been a bad thing, and it doesn't target enough the people with very complex needs, the people that we will often see in our practice. I think as it expands, I think there's more opportunity to actually look at the needs of actually older adults who often have missed out, people with intellectual disability, and people with more complex psychological needs. And I think I was talking to the medical psychotherapy faculty about this earlier on in the week, that I think that they have often felt really marginalised from a lot of what's been happening, and I think we actually need to make sure that they play a full part in that, because medical psychotherapists actually help people with the most complex psychological needs, and they're the first people that we should be prioritising, and actually they've been neglected. I mean, I guess one example would be people with medically unexplained symptoms, and that the evidence base around that, and the huge difference that psychological approaches can make to outcomes, but also people's experience, as well as actually in our general hospitals that people are often very frustrated that outcomes are poor, patient experience is poor, and people are just circulating around departments and not getting any benefit from it. So I think there are huge developments that I would anticipate across the whole of psychiatry.
Yeah, on your point, which I think is very valid about not creating this kind of false polarity between biological, psychological, etc. Do you have any thoughts on the resurgence of interest in psychedelics research? Because what they're working on really is such a combination of a biological and a psychological approach. Really, it's a biological intervention with the aim of catalyzing a psychological intervention, and of course, to some degree, that's within a social context. But do you have any particular thoughts on that?
I think it's very exciting. I think my concern about some of this is that very often this is something for real experts to actually engage with and provide these treatments for patients and make sure that people are properly monitored. And I think that you could actually just get the view from people to say, well, we just use psychedelics ourselves, street psychedelics, and that's going to do the same thing. And this is really very different. And I think we need to be very clear that that's what's happening. I mean, I'm very interested. Sue Mizzen, who was the chair of the medical psychotherapy faculty, she might even have finished it by now, but she was doing a PhD on the brain changes that happen with psychological therapies. And so this idea that you even if you don't say there's this polarity in terms of treatment or focus or what should the college be doing, actually within any of those modalities, the psychological is biological and the biological is psychological. I mean, after all, everything I'm thinking, my emotions, are being mediated by chemicals and electrical charges and impulses. So it's all of these things are actually woven into each other. So in some ways, it's always been a bit of a false dichotomy. And so I think it is very exciting, but I think we just need to be careful that people don't get carried away and that people keep to the real science behind this and the evidence base around it. It's a bit like the medicinal cannabis issue that, again, people can be self-medicating with street cannabis, which is not what the medicinal cannabis is really all about. And of course, medicinal cannabis, there's really no evidence at the moment that has any benefit for psychiatric illness.
Right. Yeah, it's easy to be polemic about these things, especially given I guess there's a historical stigma that psychedelics have to shake off. And I think some of it is deserved and some of it is not. So I think in the deserved category, you think of people like Timothy Leary, who really didn't do very much for the public perception of these drugs, and really I would say it was quite irresponsible in how he talked about them and promoted them, and that obviously culminated in his expulsion from Harvard. But then a lot of it seemed to be due to the rapid criminalization of these drugs as they got swept up in Schedule 1. It was kind of swept up in the conservative backlash against the counterculture movement. But fundamentally, I agree with you. We have to let the data speak for itself. And I think the researchers I've spoken to about it are very conscientious in that respect. And they very much say what you said, that the psychological underpinning is extremely important to have what they refer to as integration therapy alongside of the administration of the drug is crucial. Dr. James, I've taken up a lot of your time, but just to wrap up, I always ask my guests if they have a particular question that they want to ask me.
as the president of the Royal College, Alex, what do you think I should be doing, and what would be your priorities for the college?
I don't think this is necessarily the priority, but I think a priority that I care about and that strikes me as important is that getting psychiatrists back to a position where they're very well versed in psychotherapy and psychology. I think that up until the middle of the 20th century, we were real experts. Psychiatrists tended to be psychotherapists by default, and we had a wealth of expertise in terms of how people were, why they were the way they were, and how we can relate to people person to person in a manner which is therapeutic. I think once the advent of psychopharmacology came about, although it was undeniably extremely useful, I do think we doubled down in that direction, and we made some serious sacrifices in terms of our psychotherapeutic expertise. And I don't think it's really promoted as much as it should be, or incentivized as much as it should be in training. I think often in training it's thought of, except by the people who are interested in it, as a kind of unnecessary chore that has to be done alongside of training. And I think that should change, not only because of its importance with psychiatry, but really as a doctor, 90% of your job is communication with patients, colleagues, other disciplines, other doctors, relatives. And a mastery of communication skills makes you much, much more effective as a doctor. So making psychiatrists take pride in their communication skills and psychotherapy skills would be a priority that I would think about were I in your position.
Well, thanks for that. I mean, I do think that there is a real concern that I guess medicine generally, and it's probably less so in psychiatry, but you see it more because of where we came from. I think this is what you're saying is can become very transactional and sort of process driven, and I sometimes want to say the thoughtful and clever bit about it. I mean, I worked with somebody called Pat Galway, who's a forensic psychiatrist. He was also an analyst. And when you sat down with him, he would really unpick things in a way that we wouldn't do that now. I mean, some of it actually was right and some of it was wrong, but it was a very particular approach. And it was always, as a lot of things in medicine, it's about you generating hypotheses that you test out. And it was very different to the way in which a lot of us find that we have to practice psychiatry now. So I think that again, it's getting back to what I was saying at the very beginning, the humanity and the thought and getting alongside somebody and unpicking things and giving people time and developing trust. It can be, we have so many processes that we have to go through, and some of them are absolutely fair enough. Some of them to do with safeguarding, and some people who had a sort of thoughtful approach turned out to be up to no good. So we do have to be careful about it. But I think, like you, I think that's a really important point, that the really thoughtful side of psychiatry, we make sure that we don't lose that, and we grow it.
Yeah, well, I think that's a perfect point to end on. So, Dr. Adrian James, thanks very much.
Well, thank you, Alex. I've really enjoyed it. Found it very. It's sometimes interesting to think things through. I think you've practiced what you were saying right at the very end. Actually, most of the things I do, there are issues, and you give a view, and you move on to the next one. But actually, I've enjoyed thinking things through and thinking about, what do I really think about this? So thank you for the opportunity.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.